Now proceeding towards the IV cannula. Now in the IV cannula, what we need to remember, these IV cannulas are very important, guys, to secure the IV line. Okay? To give any drugs, any fluid, we require this IV cannula. There are different sizes of IV cannula and different colors of IV cannula. Right? 14 till 24 gauge we are having IV cannula. Now guys, what we need to remember regarding the IV cannula, just look over here. There is a mnemonic to remember the color of the IV cannula as well as the purpose of using IV cannula. Okay? So remember guys, first of all, look at this picture. 14 gauge is what color, guys? Orange color cannula. 16 is grey color. 18 is green color. 20 is pink color. 22 is yellow color. 24, it is wrongly given over here. 24 should be purple color. 24 is purple color. Okay. So guys, the mnemonic to remember this IV cannula colors is what? Oh great God, please bless your people. Oh great God, please bless your people. O stands for orange color cannula. Orange color, which is 14 gauge commonly used in shock. G stands for grey. Oh great God. Oh great God means what, guys? G stands for grey. Okay? One more, G stands for what? Green. Green is 18 gauge. P stands for please, yani P stands for pink in color, 20 gauge. B stands for bless, yani B stands for blue, 22. Your Y stands for yellow, which is 24, and P stands for people, which is purple, 26 gauge. Okay? In pediatric cases, we are commonly using 22 and 24. 26 is not used nowadays. 22 and 24. Whereas in general anesthesia or any anesthesia cases, 18 and 20 gauge are commonly used. Whereas for management of shock-like conditions, where you have to give good amount of IV fluid to the patient, you go for a 14 gauge IV cannula. This is regarding the IV cannulas. Okay. So now starting with what? Airway devices. Airway devices. In airway devices, we are having two types of airway. One is called as the supraglottic airway and other is called as the infraglottic airway. Infraglottic airway. In supraglottic airway devices, we are having all LMAs, laryngeal mask airway. Goodell's airway, all airway devices are supraglottic. Okay? Infraglottic airway, which goes into the trachea, is only one. What is that? Endotracheal tube. So if anyone is giving you an option to choose between LMA and endotracheal tube, which is a definitive airway, what should be always your answer? Always your answer should be what? The one airway that is going into the trachea. That will be a definitive. Why? Because once you put a device inside the trachea, then you are 100% sure that you are only ventilating the trachea. The gases are not going into the esophagus. Okay. But in LMA, the gases can enter the esophagus as well as trachea. So hence, it's not the definitive airway. ET tube is a definitive airway. Now guys, regarding the LMAs, what we need to remember, LMA, first of all, we'll discuss something about LMA. LMA is what? Laryngeal mask airway or supraglottic airway device. It's not a definitive airway. Then in which conditions you have to put this LMA? In patients who are having, or basically if the anesthetist fails to intubate. If the anesthetist fails to intubate. I am trying for intubation. I am not able to intubate. Patient saturation is falling. At least put a temporary airway and ventilate the patient. Okay? Or in cases of difficult airway. In cases of difficult airway where you have not tried intubation, and you don't want to try intubation also, put an LMA. In cases of difficult airway, or if the patient is posted for minor surgery, minor short duration surgery, 10 minutes or 15 minutes procedure, why do you go for a endotracheal intubation and all? Put an LMA, right? Now these were the indications of LMA. There are some types of LMA that we need to remember, but before going to the types of LMA, there are some sizes of LMA. The size of LMA depends upon the weight of the patient. Weight of the patient. The size of LMA most commonly used in adults is what, guys? It is size 4 and size 5. Size 4 is used in 50 to 70 kgs person. Size 5 is used in 70 to 100 kgs person. Okay? That is the size. Now in this LMA, there are two generations of LMAs. The first LMA that is being introduced, just look over here, guys. This is LMA Classic. The first generation LMA is LMA Classic. LMA Classic. Just look over here. It is having a bulb, it is having a pilot, it is having a shaft. These things are seen on the LMA Classic. Okay? Right. So LMA Classic. Next came the second generation LMA. Second generation LMA means what? In second generation, we are having LMA Pro Seal. In second generation, we are having Fast Track. We are having a Supreme LMA. We are having other things. But remember, guys, what is the difference between first and second? First generation LMA was having only one port. Only one port. Okay? Second generation LMAs have two ports. One will be the tracheal port, other will be the esophageal port, which is commonly used to introduce the Ryle's tube for gastric deflation. All second generation LMAs will have an additional gastric port. All second generation LMAs are having what port, guys? Additional gastric port through which you can deflate the stomach. Okay. So, in second generation LMA, you are having ProSeal LMA. Okay, ProSeal LMA. You are having Fast Track or Intubating LMA. Fast Track or Intubating LMA. Apart from that, you are also having Supreme LMA. Supreme LMA. Okay. Supreme LMA. Supreme LMA is made up of polyvinyl chloride. Fast Track or Intubating LMA is also used. One more LMA is there in second generation, which is called as iGel. Which is called as iGel. What is this iGel, guys? What is this iGel LMA? iGel LMA is a type of LMA which is free from any cuff. Are you seeing any cuff over here? There is no cuff. There is no pilot. Okay? All these LMAs, you are having this elliptical bulb over here, elliptical cuff over here. Whereas in iGel, is there any cuff? No. It is very easy to put. Imagine, guys, you have just completed your MBBS, you have joined the hospital, you know LMA can be easily put. But still you are not confident, if you are not confident, you can easily put an iGel. iGel can be easily put into the patient's mouth. Okay? Remember why it can be easily put. Why? Because it is not having any cuff. Normally, other LMAs you have to insert the finger into the patient's mouth and you have to lift the tongue and then insert the LMA. A bit difficult, not that difficult, guys. Most difficult is endotracheal intubation. But if you learn it, it will be very, very simple. Okay? iGel means there is no cuff, there is no pilot, and there are less chances of injury also. Okay? Right, guys. The device on your screen is nothing but what, guys? It is this is regarded as tracheoesophageal combi tube. Tracheoesophageal combi tube. Okay? In emergency scenarios, this is commonly used. In emergency scenarios where you don't know how to intubate, you can go for this esophageal combi tube. Remember guys, the beauty of this tube is what? You don't require laryngoscopy. There is no laryngoscopy required over here. Right? You take and insert this tube blindly. What can happen? The result could be either this tube goes into the esophagus or into the trachea. Okay? So after putting this tube, you have to inflate this cuff. And then you have to check whether the tube is in the trachea or the esophagus. Okay? There are many chances it might be in the esophagus. If the tube is in the esophagus, what we need to do? Then we need to inflate this cuff also. As we are inflating this cuff, what will happen? This will basically block all the secretions coming back into the tube. Yani this is preventing aspiration. This is preventing aspiration by blocking the trachea. Sorry, by blocking esophagus. Okay, now the esophagus is completely blocked. Now you can ventilate the patient through the ports which are given over here. Okay, you can ventilate the patient through these ports. This is called as tracheoesophageal combi tube. In some of the lectures I have seen people making mistake stating this combi tube as a double lumen tube. Double lumen tube is different, combi tube is different. This is a tracheoesophageal combi tube. Okay. Next guys. But if at all, if someone is asking you which is the best way to secure the airway of the patient, the answer is what guys? Is it LMA or is it the endotracheal tube? Answer is always the endotracheal tube. Endotracheal tube. Now guys, we'll discuss something about the endotracheal tube. But before going to endotracheal tube, we need to first discuss how will you put an endotracheal tube? In what position endotracheal tube is being put? So the first thing that we need to discuss is the position. The position for endotracheal intubation. This is the position required for endotracheal intubation. You make the patient lie down in this posture, which is called as sniffing morning air posture, where there is extension at the atlanto-occipital joint, extension at the atlanto-occipital joint, and flexion at the neck. Flexion at the neck or cervical spine. Okay? When you give this position, what will happen? Two axes will come together. The oral as well as the pharyngeal axis. That will basically give you a good vision for vocal cords. This is used for normal person. If a person is obese, you can't use this position to look at the vocal cords for intubation. For intubation in obese person, we use this position which is called as ramped position. Ramped position. Whenever you give this ramped position, how will you give this ramped position? You give some pillows beneath the shoulder blade of the patient, right? And then you try to intubate the patient, right? Basically, our aim is to get the oral as well as the pharyngeal axis in a normal or parallel direction, okay? So that's the ramped position required for obese person. Okay. Now guys, so after giving the position, now you take a laryngoscopy blade. Before going to the tube and all, we are discussing the position first, then we'll go for the laryngoscopy blade. Which laryngoscopy blade is required for intubation? There are two kinds of laryngoscopy blade required for intubation. One is called as a curved blade laryngoscope, called as Macintosh laryngoscope. Other is called as straight blade laryngoscope, which is Miller's. Curved blade is Macintosh, straight blade is Miller's. Remember guys, curved blade is used in adults, whereas straight blade is used in children. The reason is what? Children have a large epiglottis that can be easily lifted through Miller's. They have a large epiglottis. Children have a large epiglottis which can be easily lifted through Miller's. Right? Nowadays we are having some modifications of laryngoscope. Remember guys, we introduced this laryngoscope. Imagine we are introducing this laryngoscope in the patient's mouth. Then we lift the tongue, and then remember we lift the tongue. While lifting the tongue, the pressure of your handle should be towards the roof. As you lift the tongue, you will see the vocal cords, and then you put the endotracheal tube. Nowadays, we are having some laryngoscopes, which are basically once you put in the patient's mouth, they will be having a extra handle. You can see over here, this extra handle is over there, right? With this extra handle, once you are in the patient's mouth, just press this extra handle. This will help you to lift the tongue. You don't have to lift the tongue. Just press this extra handle, it will lift the tongue. This laryngoscope is called as McCoy laryngoscope. This is called as McCoy, C-O-Y. This is called as McCoy laryngoscope. Okay, right? And nowadays we are also having, in order to ease intubation, we are also having this device available. What is this device available? This is video laryngoscope. This is video laryngoscope. Okay, these are the modifications of laryngoscope and laryngoscopy. So basically, guys, now you have done the laryngoscopy, you have lifted the tongue, epiglottis is lifted, and you see the vocal cords. Now the next thing is what? You take the tube. What tube will you take? You will take the endotracheal tube. But before going towards endotracheal intubation, after lifting the tongue, you will see the laryngeal aperture. Laryngeal aperture is nothing but the vocal cords, the epiglottis and all. So, based upon the appearance of the laryngeal aperture and based upon the visualization of the vocal cords, there is a classification given which is called as Cormack-Lehan's grading or Cormack-Lehan's classification. Cormack-Lehan grading or Cormack-Lehan's classification based upon the visualization of the vocal cord, right? Now just look over here. In Cormack-Lehan we are having 4 grades. First grade is what? Once you do the laryngoscopy, while doing laryngoscopy, you are able to see the laryngeal aperture clearly. Everything is appearing clearly. That is grade 1. Grade 2 means what? Only posterior portion of the laryngeal aperture is seen. That is grade 2. Grade 3 is what, guys? Only epiglottis is seen. Only epiglottis is seen. And grade 4 means what? Epiglottis is also not seen. For grade 4 kinds of laryngeal aperture, it is better that you go for a video laryngoscopy for intubating the person. Otherwise, it becomes very difficult. Okay. So remember, this is Cormack-Lehan grading, which is based on the visualization of the vocal cords. But this is always done during laryngoscopy. Okay. Patient comes for PAC, you don't go for Cormack-Lehan grading and all. You can go for Mallampatti. Now, guys, in the adult patient, which is the narrowest part of the airway. In the adult patient, which is the narrowest part of the patient's airway. Narrowest part of patient's airway in adults. Come on, guys. Which one is it? It is the glottis. It is the glottis. So, in adults, the narrowest part of the patient's airway is adults. In adults, the narrowest part of the airway is glottis, whereas in children it is subglottis. In children it is subglottic area, which is very narrow. Next, guys, right? Next, this structure which is visible on your screen is called as what? This is stylet or this is the stylet. Guys, remember in difficult intubation cases, we usually put the stylet. Apart from stylet, we also use bougie. There is one more device called as what? Bougie. We use stylet, we use bougie for difficult airway management. Okay. Next, guys. Now, after doing laryngoscopy, Cormack-Lehan, everything is done. Now you have to put an endotracheal tube. Now coming to endotracheal tube, guys. Endotracheal tube. In endotracheal tube, there are 2 types of endotracheal tube. The ones which were used in olden days called as red rubber tubes, which are not used nowadays. Why we are not using these red rubber tubes nowadays? Why? Because The red rubber tubes were high pressure, low volume. High pressure, low volume cuff. They were having high pressure, low volume cuff. That was causing tracheal mucosal injury. That was causing tracheal mucosal injury. So instead of red rubber tubes, we are nowadays using what tubes, guys? We are using the PVC tubes, which are low pressure, high volume. Low pressure, high volume cuff. Okay? PVC tubes, there are two types, guys. One is the cuffed and other is the uncuffed. Right? Previously, 5 years back, it was told that uncuffed tubes are used in children, cuffed are used in adults. Why? Because tracheal diameter of the children is usually smaller when compared to adults. But nowadays, it has totally changed. Nowadays, we are having micro-sized cuffs which can be safely used in children. Micro-cuffed tubes which can be safely used in children. Okay? Now, what are the parts of the endotracheal tube? The parts of the endotracheal tube, everyone look over here. If we zoom into this part, I am just zooming into this part of the tube. Okay? If we zoom into this part of the endotracheal tube, look over here. This is the endotracheal tube. This is the bevel end of the endotracheal tube through which we are ventilating. There is one bevel end over there, and just beside the bevel end, there is one more end over here which is called as, or one more opening over here which is called as Murphy's eye. What is this Murphy's eye? What is this Murphy's eye? Remember, guys, if one opening gets blocked due to some tracheal secretions, what will Murphy's eye do? Murphy's eye provides a port for alternate ventilation. Murphy's eye is an alternate port of ventilation. Alternate port of ventilation. Okay. This is regarding what, guys? This is regarding the Murphy's eye. Right. Now, guys, apart from Murphy's eye, next part of the tube is what? The cuff. What is the pressure inside the cuff of the endotracheal tube? It is 15 to 22 mm of Hg or 25 to 30 centimeters of water. That is the pressure that is used to inflate the cuff and all. Next is what? Two markings. The markings, what is the importance of marking? The marking tells you the exact position of the tube. The marking tells you the exact position of the tube. Whenever you are placing the tube, remember this is the trachea, guys. Whenever you are placing the tube, where should you place the tube? Will you place the tube on the carina? No, sir. You will place the tube how many centimeters? You will place the tube 3 to 4 centimeters above the carina. And how will you come to know that you are 3 to 4 centimeters? When you see one mark inside the vocal cord and one mark outside it. Okay. That's regarding the markings of the endotracheal tube. Now, guys, once you have intubated the person, how will you confirm that you are in the trachea or not? For confirmation that you are in the trachea or not, you need to go for a best test. Remember, the bedside tests are, you go for auscultation and all. But the best test for indicating that you are in the trachea, or best test to confirm endotracheal intubation is capnograph. Is what, guys? Is capnograph. Capnograph is the best test for confirming intubation. Now, guys, what does capnograph mean? What does this capnograph mean? Capnograph measures the exhaled carbon dioxide. It measures the exhaled carbon dioxide or EtCO2 is measured by capnography. Now, in this capnograph, this is the normal capnograph, guys. You can see this. This is a normal capnograph. Okay, it comes like this. Normal. What is this meaning? There are 4 phases, guys. This is phase 1. This is phase 2. This is phase 3. And this is phase 0. What is phase 1? Phase 1 is nothing but dead space ventilation. Dead space ventilation. That is phase 1. Phase 2 is what, guys? Phase 2 is expiratory upstroke. As a patient is exhaling carbon dioxide, you will get this phase 2. That is expiratory upstroke. Okay? Next is phase 3. Phase 3 is what, guys? It is the alveolar plateau. Alveolar plateau. Whereas phase 0 is what? Phase 0 is inspiratory downstroke. Now the patient begins to inspire. Okay? So that is inspiratory downstroke. In between phase 1, phase 2 and 3, there is an angle called as alpha, and phase 3 and phase 0, there is an angle called as beta. This beta angle is very important. Why? Because at this angle, you will measure the exhaled carbon dioxide. This beta angle is very important because at this angle, you will measure the exhaled carbon dioxide. Okay. So that's regarding the normal capnograph. Normal capnograph reading is between 35 to 45 mm of Hg. Right. Now you need to remember what are the abnormal capnographs. Now guys, imagine after intubating a person, after some time after intubating a person, you will see a capnograph which came like this, and then slowly it became a flat line, and then first flat line was continued. When you see a flat line of capnograph or capnograph value, EtCO2 value of 0, what does it mean? Flat line means what? Either you are not in the trachea, you are in the esophagus. Now you must be wondering, if you were in the esophagus, normally it should come direct flat line. No. Why it is coming like this? Because remember, esophagus will also have some carbon dioxide. There is some carbon dioxide in esophagus. Once you put the tube in the esophagus, you will see that carbon dioxide is exhaled, and then there is no carbon dioxide. Continuous carbon dioxide is exhaled from the trachea and the lungs only. Okay. So in the case of esophageal intubation, you will see this. Sometimes you might be in the trachea, but you might see this flat capnograph. In the case of cardiac arrest, you might see this flat capnograph. Apart from that, flat capnograph value or capnograph value of 0 can also be seen in what all condition, guys? If the tube is blocked, or if the tube is disconnected. If the tube is disconnected from the circuit. Tube is disconnected from breathing circuit. Then you will see a capnograph value of 0. This is regarding what, guys? Flat line. Okay. Now, second is what, guys? You will see a shark fin pattern. Just look over here. Normal capnograph looks like this. This is the normal. But in this capnography, what is happening? You are seeing a shark fin type. Shark fin capnography is a hallmark feature of what? It is a hallmark feature of bronchospasm, which is seen in the patients of COPD as well as bronchial asthma. You will see shark fin capnography. Next is what, guys? This kind of capnography. Step ladder capnography. Step ladder meaning what? Slowly the capnography readings are slowly elevating. Slowly it is increasing. Previously it was 38. Slowly it became 42. Next it became 45. Next it became 50, 60. Right? And the capnograph value is also increasing from the baseline. Okay? But it will increase in the step ladder manner means what? Slowly the carbon dioxide is being accumulated in the patients who is suffering with malignant hyperthermia. This capnography is seen in malignant hyperthermia. Step ladder capnography. Next, the next capnograph that you see is what? First, you have to remember the normal, guys. Normal capnograph is like this. Okay? But this capnograph values from the starting only it is basically rising from above the baseline. When capnograph readings are starting from above the baseline, that indicates what, guys? That indicates that we are using exhausted soda lime. Soda lime function is to absorb carbon dioxide. But the soda lime, if it is exhausted, you will see capnograph high. Why? Because carbon dioxide is retained and that carbon dioxide is coming into the endotracheal tube. Okay. So, you will see in exhausted soda lime, you will see a high capnograph. Next is what? You will see a capnograph value like this. Yani ke It was normal, suddenly decrease, suddenly more decrease, more decrease, more decrease. यानी कि constantly, gradually, capnograph values are decreasing. It looks similar to the train of four, no? Fading phenomena of train of four, you remember? Right? Which is seen with non-depolarizing. Anyways, let's look over here. This kind of capnograph, decreasing type of capnography is seen in patients who are suffering with venous air embolism. Venous air embolism. Now guys, venous air embolism is seen in what patients? What patient will you see venous air embolism? What patient will you see venous air embolism? Just look over here guys. Imagine a patient is posted for some surgery in this position. If you do surgery in this position, some surgery in this position, especially the neurosurgeries, the posterior fossa craniotomies, surgeons require this position. Why? Because surgeon will be telling that in this position the intracranial pressure will be low, right? But what happens guys in this position? There is much chances that the air might go into the major blood vessel leading to a complication called as venous air embolism, VAE. Venous air embolism is commonly seen in this position. Okay. So look over here guys. If at all during surgery the patient develops venous air embolism, you will see this capnograph. Apart from that, what else you will see guys in venous air embolism? Remember a few points of venous air embolism, we know that it is seen in surgeries done in sitting position. Apart from that, the best investigation for venous air embolism is what guys? Best investigation for VAE is TEE, which is transesophageal echocardiography. Apart from that, what else we need to remember of venous air embolism? What is the murmur that you see in venous air embolism? The murmur that you see while auscultating is windmill murmur. Windmill murmur. Windmill murmur. Okay. That's venous air embolism. Okay guys. So you will see this kind of capnograph in venous air embolism. Next. The last capnograph that we see is what? This capnograph. So basically I'll give you a case. Just look over here. After intubation, you are seeing a normal capnograph like this. Then after, in the maintenance phase also, you were seeing this capnograph only. You were happy, patient was happy, everyone were happy. Okay? Then after 30 minutes, suddenly you will see this kind of capnograph. Suddenly you will see this kind of capnograph developing. Yani what does that mean? Something abnormal is happening over here in the alveolar plateau phase. What is happening guys? Remember in this patient was fully paralyzed under the muscle relaxant effect. When he is fully paralyzed under the muscle relaxant effect, there won't be his efforts. There won't be any patient efforts. When a person is fully under the effect of muscle relaxant, you won't feel or you won't see any efforts from the patient. So you will see a flat line or a flat or a smooth capnography in the alveolar phase. But as soon as this patient, after 30 minutes, or muscle relaxant after 30 minutes, after 30 minutes, what happens? The effect of muscle relaxant is gone. Now slowly there is an effort from the patient. That means this effort is called as, this notch that is developing is called as Curare notch. That means the patient has returned spontaneous breathing. Return of spontaneous ventilation or return of spontaneous breathing gives you this Curare notch. What will you do guys if you see this kind of Curare notch? You will first ask the surgeon how much time more will take for the surgery. The surgeon will tell more 1.5 hours. So what we need to do guys? Will you continue the surgery in this manner? No. What we need to do? You need to, the next step, when you see this Curare notch, the next step that you need to do is, you need to give a muscle relaxant. You need to give the top-up dose of muscle relaxant. You need to give the top-up dose. You need to give top-up dose of muscle relaxant. Okay? That's regarding what? Capnography. Other forms of endotracheal tube. In the other forms of endotracheal tube, we need to remember this tube. This is called as a flexometallic tube. Flexometallic tube means no matter how much you bend, it won't kink. This flexometallic or armored tube is used for surgeries done in prone position. Surgeries done in prone position. Normal tube if you take, then what will happen? It will kink. Surgeries which are done in this prone position, you use that flexometallic or armored tube. Okay. Next kind of endotracheal tube that we need to remember is what? This is called as the double lumen tube. The double lumen tube. Double lumen tube. Remember guys, the tracheoesophageal combi tube is different. There you were seeing a yellow bulb, and that yellow bulb you can fill some 100 ml of air. Okay? Double lumen tube is different from that. Double lumen tube is used for what surgeries? Imagine there is a patient who is posted for lung cancer. Lung cancer surgery. Okay? He is having lung cancer and surgeon wants to remove this tumor. Can you put a normal endotracheal tube and do the surgery? No, sir. Why? Why? Because the surgeon is operating. Remember, imagine this is the left lung and this is the right lung. Okay. So, just look over here. Can you do the surgery using a normal PVC tube in this patient? No. Why? Because if you use a normal PVC tube, the gases will enter the left as well as the right lung. So, the surgeon will be telling you what? I don't want this tube. For this surgery, I want a tube that is basically ventilating only one lung. So the tube that is used for one lung ventilation is a long tube called as double lumen tube, where you take this endotracheal tube, advance into the trachea. Once you feel the resistance, you just rotate the tube into the side where you have to put it. Okay? One will be the bronchial lumen, other will be the tracheal lumen. Okay? So that is a double lumen tube, always used for what surgeries? Surgeries requiring one lung ventilation. Surgeries requiring one lung ventilation. Okay? The best way to know that your double lumen tube is in a normal position or your double lumen tube is placed properly. The best investigation to know whether your double lumen tube is placed normally or not. What is that investigation called as? That investigation is the fiber optic bronchoscopy. Fiber optic bronchoscopy. With fiber optic bronchoscopy, we can easily know the placement of the double lumen tube. It is used for DLT placement. Okay, next. This is raised tube, guys. This tube on your screen is called as a raised tube. In raised tube, you will be having south facing and north facing. Yani one facing towards the leg, the opening is facing towards the leg. Once you put this tube inside the mouth, the opening of the tube is facing towards the leg. North tube means opening of the tube faces towards the head. Okay. So anyways, raised tube is a nasotracheal tube. It is a nasotracheal tube commonly used for oral pathologies. Whenever the surgery is of the oral cavity, you can't put the oral tube, you have to put the you need to put the raised tube. Raised tube is ring, the full form of raised, ring, Adair, Elvin. Ring, Adair, Elvin tube. Okay. Next guys. So anyways, after putting any kind of endotracheal tube, you have to give gases. How will you give gases? The gases are usually connected to a machine. The gases are usually coming from the machine. Okay? Because on the machine you are having cylinders and all. So that machine that we commonly use in anesthesia is called as what machine? The anesthesia machine or Boyle's machine. Boyle's machine. This Boyle's machine was introduced in the year 1917 by Dr. Edmund Gaskin Boyle, and it is called as Boyle's machine. It is a continuous flow machine. It is a continuous flow machine. Okay. Now we need to discuss some parts of the machine. In the parts of the machine, first remember machine is divided into two systems, guys. It is the high pressure system, intermediate pressure system, and low pressure system. In the high pressure system, we are having cylinders, we are having yoke valve assembly, pressure gauge, and pressure reducing valve. In intermediate pressure system, we are having flow control valve, we are having oxygen nitrous proportionating devices, oxygen flush, and central supply of gases. Whereas in low pressure, you are having rotameter, vaporizer, and the breathing circuits, which are common gas outlet. Now guys, the questions are not asking about high, intermediate. The questions are asked about the parts of the machine. The first part of the anesthesia machine is called as cylinder. Cylinder. Now guys, in this cylinder, what we need to remember is what? Two things we have to remember. Right? In the cylinder, we have to remember two things. The first thing is, what is the material used to make the cylinder? Come on guys, what is the material used to make the cylinder? It is molybdenum, but these are non-MRI compatible. Non-MRI compatible. Right? MRI compatible cylinders are made up of aluminium and titanium. Aluminium and titanium. Okay, MRI compatible cylinders. Okay. Next guys, what else we need to remember? These cylinders are given different color coding so that by just looking at the color of the cylinder, you can easily identify, or you should easily identify what gas it is, what gas is present. Remember guys, for oxygen cylinder, what is the color coding? First, we'll go for the common gases, which could be asked guys. Oxygen. Oxygen is like a bodyguard to us. Whenever any person keeps a bodyguard, what is the color dress of the bodyguard? He will be wearing what? Black safari, yani black body. And how will be the shoulder cufflinks of the bodyguard? It will be white. So black body, white shoulders. Oxygen is also like a bodyguard to us. So hence the color coding for oxygen cylinder is black body, white shoulders. Okay. Next. After oxygen, what is the next cylinder that we need to remember is what? Nitrous. Come on guys. Nitrous yani ke nitrous neela yani ke what cylinder? Nitrous is stored blue color cylinder. Next is a gas which is called as Antonox. There is a gas which is called as what guys? Antonox. Antonox means what? Antonox is blue body and white shoulders. Blue body and white shoulders. First of all guys, what is Antonox? Antonox is 50% of oxygen, 50% of nitrous. This is commonly used for labor analgesia. This is only used for analgesia guys. It never produces anesthesia. No anesthesia is seen with Antonox. There is no anesthesia. Only analgesia is seen with Antonox. Okay. So oxygen, nitrous, Antonox. Apart from that, what are the other gases that we need to remember? Helium. What is the color coding for helium cylinder guys? Helium cylinder is brown color. Right. Helium is brown color. Cyclopropane is there. Cyclopropane, which is orange color. Cyclopropane, which is orange color. These are the commonly asked cylinder. One more, halothane guys. Halothane. Halo is hell. Hellfire is red in color. So halothane cylinder is red color. Halothane is stored in red color cylinders. Right. So that was regarding what guys? That was regarding the color coding of the cylinders. Color coding of cylinders. Okay. Right. There is 8 cylinder also. What is 8 cylinder guys? 8 cylinder color. The color of 8 cylinder is what? It is white body, black shoulders. White body and black shoulders. That is a air. Nitrogen cylinder is there, which is completely black. So anyways guys, regarding color coding, just remember the most common ones. Oxygen, nitrous and Antonox. These are common ones. Okay. Right. Next. Now, these cylinders are attached to the machine with the help of yoke valve assembly. In the yoke valve assembly, we have a system that prevents wrong attachment of the cylinder. What is the system called as? That system is called as pin index system. Very, very important, guys. Pin index system prevents the wrong attachment of the cylinder. For different gases, different pin index system are given. Such as for air, there is some pin index system. Oxygen, there is some pin index system. Nitrous, NOx, carbon dioxide. Okay. Air, what is the pin index system, guys? Remember, first of all, just look over here. Just a brief review of pin index system. 1, 2, 3, 4, 5, 6 and 7. Pin index system means what, guys? Pin index system means the holes are present on the cylinder and pins are present on the machine. Okay? If that cylinder corresponds to that cylinder is having that pins, then only it will fit into the anesthesia machine. Now, guys, for air, the pin index system that is commonly given is 1, 5. For oxygen, 2, 5. Nitrous, 3, 5. NOx, 7. When I am telling air is having a pin index system of 1, 5, what does it mean? If it is an air cylinder, it will fit into the first and fifth port. Okay? 3 pin index systems you can easily remember. Why? Because most of them, 3 of them are ending with what? 5. The second pin index system is 5. And again, all are occupying the fifth port. Right? The first thing that we have to remember, the first pin index system we have to remember. So look over here, guys. Air pin index system is 1, 5. How will you remember air pin index system is 1, 5? Air is starting with the alphabet of A. Alphabet of A is the first alphabet. So, air pin index system is 1. Okay? 5. A is first alphabet. So, it is 1. Then second is always 5 only. Oxygen. Whenever you are writing oxygen, don't write oxygen like this. Always write O2. O2 means it will be, that 2 will come over here. It will be 2, 5. Nitrous means 2 molecules of nitrogen, 1 molecule of oxygen. It will become 3. So, it is 3, 5. NOx, the alphabets in NOx is 7. So, the pin index system is 7. Carbon dioxide, it is 1, 6 and 2, 6. The color coding for carbon dioxide cylinder, I forgot to tell, it is grey in color. Carbon dioxide is grey in color. Guys, remember in the color coding, oxygen, nitrous, NOx and carbon dioxide. These are important ones. These are very, very important. Okay. Now, so guys, remember, imagine you're doing a case and during surgery, the patient is suddenly desaturating and you see that the cylinder, the pressure inside the cylinder is 0. The gas is totally exhausted. Now you check for other cylinders. There is no cylinders available in the hospital. What will you do, guys, in this scenario? You have to cut down the gases from the anesthesia machine and shift to the central supply. The central supply of gases. Okay? In the central supply of gases, there is a safety system. In the central supply of gases also there is a safety system that prevents the wrong attachment of the gases pipes. What is that system called as? That is a non-interchangeable system which is called as diameter index safety system. Okay. So the central supply of gases, the pressure of air in the central supply of gases is how much, guys? 60 psi. And I told you there is a safety system that prevents the wrong attachment of the gases pipes and all. Okay. It's a standard to provide the non-interchangeable connection, which is called as diameter index safety system. Okay. Next thing in the anesthesia machine that we need to discuss is about the vaporizer. What is the function of vaporizer, guys? We are going for the parts of anesthesia machine and now we are discussing about vaporizer. Vaporizer is a device that stores the liquid inhalational agent. It stores the liquid volatile inhalational agents in it. Vaporizer is made up of what material? It is made up of copper material. Normally, all the gases are stored in one type of vaporizer, but desflurane, as it is having a low boiling point, it requires a special vaporizer, which is Tech 6 vaporizer. Special vaporizer, which is Tech 6 vaporizer, which is very costly. Desflurane requires a special vaporizer which is very costly. Now guys, there are some colors of vaporizer that we need to remember. Once again guys, the gases that are commonly used are HIST. H stands for halogen, I is for isoflurane, S for sevoflurane, D is for desflurane. Okay. Halothane, what is the color of the vaporizer of halothane? Halothane, halothane, hellfire is red in color, so it is a red. The color of the vaporizer of halothane is red in color. Whereas isoflurane, what is the color of the vaporizer of isoflurane? It is purple color. Purple color. Sevoflurane, what is the color of sevoflurane vaporizer? Sevo is sweet. Sevia is also sweet. I used to remember Sevo as Sevia. Sevia, color of the Sevia is what? Yellow in color. So sevoflurane, what's the color guys? It is yellow in color. Sevoflurane is yellow in color. Last is what guys? Desflurane. Desflurane, what's the color of vaporizer? It is, remember guys, Des. I used to remember Des as Desi. Desi. Desi means what? Remember in America, in US or in this UAE also, in United Arab Emirates also, they call people from India, Pakistanis and Bangladeshis as Desis. Okay? But in US and all, usually Desis are the persons who are belonging to India. Desi है बोल तो Indian है. So remember guys, desflurane, Desi. Why we need to remember Desi? Desi यानी कि India, the cricket players of India, they wear what color jersey? Blue color. So remember, desflurane is Desi, hence it is blue color, right? So this is regarding the color of vaporizers to remember. Okay. Now guys, next coming to the anesthesia circuit, so the breathing circuits. Now in the breathing circuits of anesthesia, what we need to remember, there are two kinds of circuits. But before these two kinds of circuits came, there was a circuit before it that came which was called as open circuit. Open circuit, where we used to give the gases without using any pipes. With the help of a mask. In open circuit, the mask that was used was called as Schimmelbusch mask. Schimmelbusch mask. Okay, Schimmelbusch mask is used in open circuit. But that is not used. Why? Because the exact concentration of the inhalation agent that we were giving was not able to be measured. So, instead of open circuit, we are using what circuits nowadays? We are using the semi-closed and the closed circuits. Semi-closed circuits are also called as Mapleson circuit. Whereas closed circuit, there is no name for it. Semi-closed were introduced by Mapleson. Hence, they are called as Mapleson's breathing circuit. Now guys, what we need to remember in this Mapleson's breathing circuit, they are Mapleson A till Mapleson F circuit. They are Mapleson A till Mapleson F circuit. The easy way to remember this Mapleson A till F is what guys? Look at this valve. First of all, you need to understand. This is the mask. This is the expiratory valve. This is the corrugated tube. And this is the reservoir back. Okay. Now guys, if in Mapleson A, B and C, one thing is common. What is that thing common? The expiratory valve is close to the patient. The expiratory valve is close to the patient. So in order to remember the diagram of circuit, remember the expiratory valve close to the patient is Mapleson A, B and C. But if expiratory valve and fresh gases are close, then it is B and C. Okay? If expiratory valve plus fresh gas flow is near to the patient, then it is B and C. Okay? A, B and C, expiratory valve is close, and if it is expiratory valve plus fresh gas flow is near, then it is B and C. Okay? Now, expiratory valve away from the patient is D. Expiratory valve away from the patient is D. Whereas Mapleson E and F are valveless circuit. They are valveless circuit. right? Mapleson E is valveless as well as bagless, yani ke without bag also. Just to identify the diagrams, I have written this, guys. Okay? So just to identify the diagrams, expiratory valve is close. We have discussed A, B, and C. Okay. Now guys, just look over here. What we need to discuss now, Mapleson A circuit. Mapleson A circuit, also called as McGill circuit. It is a circuit of choice for what ventilation? It is a circuit of choice for spontaneous ventilation. When you use a circuit for spontaneous ventilation, the fresh gas flow that you keep will be the equal to minute ventilation or minute volume. Okay, minute volume is nothing but tidal volume into respiratory rate. The fresh gas flow that you need to give in order to prevent rebreathing is equal to the minute volume. But in rare cases, if you use Mapleson A for control meaning ventilator controlled ventilation. Okay? If you are using for controlled ventilation, then the fresh gas flow should be 1.8 to 2 times the minute volume. Okay? Remember, just it is a circuit of choice for spontaneous. B and C are not used. These are used for transportation. Mapleson D circuit is also called as Bain circuit. It is also called as what circuit, guys? Bain circuit. One thing is common in A and D circuit. What is the thing that is common in A and D? Both are coaxial circuits. What is meant by coaxial? In the corrugated tube, you are having one more inner tube. In Mapleson A circuit, the inner tube is responsible for, expiratory gases, whereas the outer tube is responsible for inspiratory gases. Whereas in the case of Bain circuit also there are two tubes. The inner tube is responsible for inspiratory, outer is responsible for expiratory. This is a circuit of choice for controlled ventilation. Very, very important. And whenever you are using the circuit for controlled ventilation, the fresh gas flow should be equal to how much, guys? 1.6 times the minute volume. 1.6 times the minute volume. If you are using for control. If you are using for spontaneous ventilation, then the fresh gas flow should be 2 to 3 times the minute volume. Okay. So anyways, guys, you have to remember the controlled values only. Okay. Control values for this and spontaneous value for this. Okay. So this is regarding what? D. E and F are valveless and valveless circuit. Right. Mapleson E is also called as ISTPs. It is also called as ISTPs. Mapleson F is the circuit of choice for controlled as well as spontaneous ventilation in pediatrics. Controlled, it is a circuit of choice for controlled as well as spontaneous ventilation in pediatrics. Okay, that's regarding what? That's regarding the Mapleson circuit. Coming to the last circuit, which is called as closed circuit. Closed circuit. In closed circuit, remember there is no expiratory valve. All the gases are going and being absorbed. Not all gases, only one gas get absorbed. All the gases, all the exhaled gases through the expiratory limb go into this chamber, which is called as carbon dioxide absorbing chamber. In this carbon dioxide absorbing chamber, there are two materials. One is either soda lime, other is bara lime. Other is what, guys? Bara lime. Right? So, soda lime or either bara lime. Now look over here, guys. These gases go into the soda lime and what will happen? Carbon dioxide gets absorbed. Right? What is the soda lime made up of? That was the question. Soda lime is basically made up of 80% of calcium hydroxide, 16% water, 3% sodium and 1 to 2% of potassium hydroxide and silica. Now guys, remember the main components. Remember the major component of soda lime is what? It is the calcium hydroxide. Whereas the main component of soda lime is what? sodium hydroxide. Silica is added to increase the hardness of the granule. Silica is added to increase the hardness of the granule. Guys, remember, whenever you are using closed circuit, some inhalational agents have to be avoided. The inhalational agents that need to be avoided when you are using closed circuit. Why? Because they react with soda lime. What are the inhalational agents avoided are CT scan. The inhalational agents which are avoided with soda lime are CT scan. C stands for chloroform. T stands for trilene. S stands for sevoflurane. Okay? If you give CT scan to the patient, they might be if you give these agents will react with the soda lime to form some toxic compounds. Okay. Next is baraline. Baraline is made up of 80% of calcium hydroxide and 20% of barium hydroxide. Whenever you are using baraline, again some agents needs to be avoided. Dye agents need to be avoided with baraline. Why? Because patient might die. Means what? D stands for desflurane. If you give these agents, patient might die. I stands for isoflurane. E stands for N-fluorane. E stands for N-fluorane. Right? Why? Because they react with baraline to produce carbon monoxide, and the agent that produces much carbon monoxide is desflurane. Much carbon monoxide is seen with desflurane. Okay? That's regarding the soda lime and baraline. Okay? Let us just start with the brief review of ventilators. Guys, remember, whenever you hear about this term ventilator, you might be confused how to set the ventilator and all, right? I'll just give you a brief review. Why? Because we have discussed in detail in the full lecture, okay? So look over here, guys. Whenever you are going to a ventilator, first of all, ventilator is required for what patient, guys? Ventilator is required for the patient who is not able to maintain a saturation with a normal oxygen mask or other oxygen devices. So that patient requires a ventilator. Remember, guys, when in ventilators, before setting a ventilatory mode, you need to understand one thing in your mind. One thing of the either you can set. Either you can set the volume or either you can set the pressure. If you set the volume, then ventilator will take care of the pressure. If you set the pressure, then ventilator will take care of the volume. Okay? So either you can set the volume or either you can set the pressure. Okay? That is the basic thing. Okay? Setting the volume means setting the tidal volume. Setting the pressure means setting the pressure at which the gases are delivered to the patient. Okay? Normally we go for volume mode. Volume mode. You set the volume and ventilator decides the pressure. Now guys, imagine a person is there who just met with a road traffic accident and he is totally in a gasping state. He is not at all breathing. Right? We gave him CPR and we connected, there was return of spontaneous circulation, and now we shifted the patient into the ICU. In the ICU, on the ventilator, there will be these modes of ventilator in front of you. What is the mode that you will choose for this patient who is not having any breathing efforts? The patient who is not having any breathing efforts, in that patient, you want the ventilator to solely and take the full responsibility of the patient's breathing. That mode that takes the full responsibility of the patient's breathing is what, guys? It is the continuous or controlled mandatory ventilation. Controlled mandatory ventilation. Okay, this mode of ventilation, CMV mode, is basically the big boss of the ventilator. In this mode, nothing is given by the patient. There is no respiratory efforts. No respiratory efforts is allowed to the patient. There is no trigger breathing allowed to the patient. What do? You on this mode and you heavily sedate the patient and heavily paralyze the patient. So remember, CMV mode is the big boss of the ventilatory mode. Okay, it takes care of the patient's ventilation. There is no triggered breathing allowed over here. Patient is heavily sedated and paralyzed. Then there is assist control mode. Assist control mode, ACMV. Okay, assist control mode of ventilation. In this assist control mode of ventilation, we are having volume control and pressure control. Volume control and pressure control, right? This ACMV mode, we are having two of these modes. Remember guys, here you are still sedating the patient. You are still sedating the patient, but the sedation is a bit decreased. You are moderately sedating the patient. Why? Why? Because here the trigger breathing is allowed. Here the patient's trigger breathing is allowed in this mode, right? Then there is what? Pressure support mode. Pressure support mode means what? Now you feel that this patient requires less amount of ventilator, just he requires some support. Some support. He is breathing, but he requires some support. Then means that mode is what guys? Pressure support. Pressure support is just a supportive mode. It is a supportive mode of ventilator. Next is SIMV. SIMV is what guys? Synchronized intermediate mandatory ventilation. SIMV. This is basically a weaning mode of ventilator. It's a weaning mode of ventilator, or it is a spontaneous mode of ventilator. Spontaneous mode means what? Just look over here guys. Spontaneous mode of ventilator means what? Right? The patient is having good breathing. The patient is having one more good breathing. Okay? These are the two breaths given by the patient. Now the patient is still not, he's not recovered fully. Now he's become weak in the next breath. Right? In the next breath, the ventilator picks up, and what will it do? It takes the responsibility and delivers the breath. It takes the responsibility and delivers the breath. Okay, then again the patient is breathing. So basically, SIMV is what guys? It is a weaning type of mode. As the patient is tolerating the pressure support and all, then you can go for SIMV mode to look whether we can wean the patient off from the ventilator. There are other weaning modes also guys. There are other weaning modes also. Apart from SIMV, there is CPAP mode, BiPAP mode, all are there. Okay. So anyways guys, these are the few ventilatory modes. For ARDS patient, we go for inverse ratio ventilation, prone position ventilation, and airway pressure release ventilation. In emergency scenarios, we use high frequency ventilation. High frequency means what? Such as you have done an emergency tracheostomy. The patient was desaturating, you were not able to ventilate, you are not able to intubate. In that scenario, you go for tracheostomy. There you go, you need to go for high frequency ventilation, which is further divided into high frequency oscillatory and high frequency jet ventilation. In high frequency jet ventilation, we give, the rate is very high guys, 120 to 80 breaths per minute. Whereas in high frequency oscillatory, the rate is more high, 300 to 900 per minute. 300 to 900 per minute. Okay. Now guys, while setting the ventilator, you also set a thing called as PEEP. PEEP. What is meant by PEEP? PEEP is nothing but positive and expiratory pressure. Yani basically, what is that guys? It is the pressure required to open it is the pressure required to keep the alveoli open at the end of expiration. It's the pressure required to keep the alveoli open at end of expiration. That is called as PEEP. Okay? PEEP is used for ARDS patient. PEEP is used for many conditions, guys. Pulmonary edema and all, you can use this PEEP. Okay? But the disadvantage of this PEEP is what, guys? Disadvantage of PEEP is what? It will decrease the venous return, decreases the cardiac output, and thereby causing hypotension. It will also increase the intracranial pressure. It will also increase the intracranial pressure. So, in patients who are having head injury and all, we avoid using PEEP. PEEP is positive and expiratory pressure. PEEP is positive end expiratory pressure. Okay, guys? So guys, as we were discussing the ventilators, I told you there is invasive and non-invasive ventilator. Invasive mode of ventilation we have already discussed. Remember guys, non-invasive mode of ventilation. Remember, non-invasive mode of ventilation is used for what patients? Non-invasive mode. Non-invasive mode of ventilators is commonly used for the patients who are not able to maintain the saturation, but they are still conscious. Non-invasive is basically the BiPAP mode. Okay, it is commonly used in conscious patient. We can't use non-invasive mode in unconscious patient. If you use the non-invasive mode for unconscious patient, there are many chances that the patient might land up into aspiration. The patient might have aspiration. Okay, those were the modes, or those were the ventilatory modes. Okay, now guys, coming to the next thing, which is oxygen delivery devices. Oxygen delivery devices. In the oxygen delivery devices, we are having two kinds or two types of oxygen delivery devices. One is called as the low flow variable performance oxygen delivery devices. Another is called as the high flow fixed performance oxygen delivery devices. High flow fixed performance oxygen delivery devices. In the low flow variable performance oxygen delivery devices, we are having the nasal cannula, the face mask, the NRBM, which is a non-rebreathing mask. Whereas in the high flow, we are having HFNC. What is HFNC? High flow nasal cannula and Venturi mask. Venturi mask. Now guys, what we need to remember, there have been questions that's being asked about how much this oxygen delivery device will deliver, how much of FiO2 or how many liters of oxygen can be delivered through the through this device and all. Okay, for that, just look over here guys. Here I have written the device name. In the next column is the flow rate, and then in the next column it is the FiO2. Okay? So basically the first oxygen delivery device. Imagine guys, the patient is coming in an emergency scenario where his oxygen saturation is being dripping. In that patient, the first thing that we need to connect him an oxygen. How will you connect him oxygen? Through a nasal cannula. The first device that we use is a nasal cannula. The nasal cannula, in the nasal cannula, the flow rate, the maximum flow rate of oxygen that you can give is 1 to 6 liters. And when you are giving this flow rate, how much of FiO2 you can achieve, how much of fraction of inspired oxygen you can achieve, guys? The FiO2 that you can achieve is 25 to 45%. 25 to 45% with nasal cannula. Next, if at all his saturation is not improving, you remove the nasal cannula, you keep him on face mask. This device on the screen is called as what, guys? A simple face mask. This is called as a nasal cannula, guys. This is called as nasal cannula or nasal prawns. Okay. Whereas this device is called as simple face mask. So the second device that comes to your mind is simple face mask. In simple face mask, remember, nasal cannula was delivering up to 6 liters. Simple face mask will deliver 6 to 10 liters of oxygen. We can deliver 6 to 10 liters of oxygen, and which can achieve an FiO2 of 35 to 60%. Right? Now, still he is not improving. Then we go for a non-rebreathing mask. Yani a simple face mask connected to a non-rebreathing bag is called as NRBM. This is the NRBM, guys. This is the non-rebreathing bag. A simple face mask connected to a non-rebreathing bag. Okay? With this, how much of oxygen can you deliver, guys? 10 to 15 liters of oxygen can be delivered, and you can achieve an FiO2 of how much? 65 to 95%. 65 to 95%. Now imagine the patient is still not improving. Then you go for a high flow oxygen delivery devices or fixed high flow oxygen delivery devices, which are what, guys? Which are called as Venturi mask and HFNC. Now Venturi mask delivers how much, guys? Venturi mask The flow rate that you can give to the venturi mask is what? You can deliver 2 to 15 liters of oxygen to the patient, by which the patient can achieve an FiO2 of 24 to 60%. Okay? The last is what, guys? The high flow nasal cannula. With this high flow nasal cannula, the flow rates of oxygen that you can deliver, it is very high. 40 to 60 liters of oxygen you can deliver, by which you can achieve an FiO2 of 100%. 100%. So remember, guys, stepwise: nasal cannula 1 to 6 liters, then simple face mask 6 to 10 liters, then NRBM 10 to 15 liters. Done. High flow means you are having two devices. What two devices? The venturi mask and the high flow nasal cannula. High flow nasal cannula. Okay. Now, guys, what does we need to remember? This is the nasal cannula, guys. This is the simple face mask, right? This is the non-rebreathing bag, right? And this is the venturi mask. This venturi mask works on a principle. What principle it works on? It works on Bernoulli's principle. It works on Bernoulli's principle. Right? You can see over here, there are different colors given for interchangeable venturi valves. There have been questions on the colors of the venturi valves, the flow rates that you are giving, and the FiO2 concentration of the oxygen that you are achieving. For the color coding of the venturi valves, there is a mnemonic that we need to remember. What's the mnemonic for it, guys? The mnemonic is, boy was often yelling, run girl. Whenever you apply a venturi mask to a boy, he often yells, run girl. Boy was often yelling, run girl. Now, guys, what is this with mnemonic? Okay? When you remember the mnemonic in this line, you can remember many of the things, guys. In this, B stands for blue. The boy B stands for blue. W means it is white. Often means O. O means it is orange in color. Okay? Yelling means, Y means yellow in color. R is red in color. And G is green in color. Okay? Boy was often yelling, run girl. Right? Now, guys, what we need to remember with this, you also need to remember about the flow rate of the oxygen. We need to understand the flow rate of the oxygen that we can deliver through venturi is how much, guys? It is 2 to 15 liters of oxygen. So obviously we'll start the 2 from here, and thereafter you just add 2 liters. 2 liters of oxygen can be given through blue. Okay? More 2 you add. 4 liters can be given through white, 6 through orange, 8 via yellow, 10 liters through red, and just add 15 to the green. 15 liters can be delivered to the green. So this is the flow rate of the oxygen. This is the flow rate of the oxygen. Next, what is the FiO2 that you are achieving? With blue venturi, the FiO2 that you achieve is, first of all, you need to remember, guys, the FiO2 of venturi is how much? 24 to 60%. With blue, how much of FiO2 we are achieving? It is 24%. Whereas with white, how much of FiO2? More 4% you add? 28%. With orange, how much of FiO2? More 3 to 4% you add? 31%. With yellow, how much of FiO2? 35%. With red, how much of FiO2? Add more 5% over here. 40%. Whereas with green, how much of FiO2 you are achieving, guys? As you are delivering 15 liters. You are not delivering 12 or 13. You are delivering 15 liters. So 60% of FiO2 is achieved. So FiO2 that is being achieved through venturi is 24 to 60%. Okay, guys? So that is regarding the flow rate, and that is regarding the FiO2 that you achieve through the venturi. The mnemonic once again, guys. Boy was often yelling, run girl. Okay. Now, guys, coming to ACLS. Come on. What is meant by ACLS? ACLS is nothing but advanced cardiac life support. Life support given to a person or life support given to a cardiac arrest patient with medical equipments and drugs. Okay. Now guys, in ACLS, what we need to remember is ACLS is a teamwork. It does not rely on one individual. There is a team of doctors or paramedical in which one is the team leader. Other is what, guys? Other one is giving the chest compression. The next one is giving the rescue breaths. And next person is giving the drugs. Next person is using the defibrillator. And the last person is the one who is noting all the things. Yani ki he is the timer. Okay, this is the teamwork. Now guys, imagine a patient develops cardiac arrest inside the hospital. You have to start your ACLS. When he develops cardiac arrest inside the hospital also, okay, the first step is what? It is scene safety. Once the scene is safe, you look for this potential hazards nearby the patient. Okay, once the scene is safe, the second step is what, guys? Next is you look for the check for the response. You check for response. If no response, the third step is what? You call for help. Okay? Or you are in the hospital, so you activate the emergency response system over here. You activate the emergency response system. Next fourth is what? You check for the pulse as well as breathing. Which pulse you need to check, guys? Which pulse you need to check? You need to check for the carotid pulse. You need to check for the carotid pulse. Whereas in adults you go for carotid pulse, whereas in children you go for the brachial pulse and all. Children yani ki infants, not children, infants you go for brachial pulse. Okay. Next, if there is no pulse, no breathing, you start your CPR or CPCR. Both is the same. Yani ki you start your chest compressions and all. Now guys, we are discussing about the ACLS algorithm. Just look over here. This is the ACLS algorithm. So when the patient is having no pulse, I told you what you need to start. When the patient is having no pulse, immediately you start your CPR. You give some oxygen, you start your CPR. Now guys, as you have started your CPR, your friend and other team members came. Your friend came with a defibrillator. What will you do? First connect the defibrillator and you go for the rhythm check. Okay? You need to check for the rhythm. If the rhythm is like this, or if the rhythm is like this, a scribbling type of rhythm on ECG. If the rhythm is like this is called as VT, which is ventricular tachycardia. If the rhythm is like this, which is called as VF, ventricular fibrillation. In these two scenarios, immediately you have to give a shock. Immediately a shock should be delivered, right? While giving a shock, always you have to deliver a shock in asynchronous mode. In asynchronous mode. And in the asynchronous mode, again you are having two phases. One is called as the monophasic, other is called as the biphasic. If you are using a biphasic defibrillator, the shock that you deliver is 120 to 200 joules. Initially you start with 120 and slowly you increase it. If you are going with a monophasic means single man army, only one extreme joule shock should be given, which is 360 joules. Okay, so either of the modes of defibrillator you can use to deliver the shock. So immediately, if you see these two rhythms, then only you will deliver the shock. And once you deliver the shock, again, don't check for the pulse and all. Once you deliver the shock, you again continue your compressions and try to secure an IV line of the patient. Okay. Now, next, after 2 minutes, what will you do? After 2 minutes, you stop. You check for the pulse as well as you check for the rhythm. While you are checking for the rhythm is still showing shockable. Shockable means what? You are still showing VT or VF. Then again, you have to give shock. Right? Again, you have to give shock. And after shock, immediately start your CPR. The second shock you have delivered and you have started again, resume your CPR. Now, while resuming your CPR, you have already secured an IV line, so you have to give some drugs to restart the heart. What is a drug? That is a drug of choice to restart the heart. It is the epinephrine. Epinephrine every 3 to 5 minutes have to be given. How will you give epinephrine? The best route is by IV route. Intravenous epinephrine, if you are giving, then you have to give 1 milligram. If IV is not possible, you go for IO route, intraosseous. If IO is also not possible, you go for endotracheal route. But if you are going for endotracheal route administration of epinephrine, then you have to give it 2.5 milligrams. Okay. So anyways, you are giving epinephrine. Now after giving epinephrine, after giving your compressions, again stop for 2 minutes, check for the pulse and again for the rhythm. And here also rhythm is showing shockable. Here also rhythm is showing what, guys? Shockable. In this scenario, again what we need to do, if it is again showing a shockable rhythm, then what we need to do, then again you have to deliver the shock. Shockable rhythm means VT and VF, deliver the shock. But now after delivering the shock, instead of adrenaline and all, what we can give, guys? You can go for amiodarone. You can go for amiodarone. Amiodarone. Amiodarone is an anti-arrhythmic drug. With amiodarone, you can, if not amiodarone, you can also go for lignocaine. It is also having anti-arrhythmic properties. The dose of amiodarone that you need to give over here is how much? 300 mg direct. 300 mg bolus you need to give amiodarone. Okay, that's regarding the shockable rhythm. But after giving amiodarone and all, still you are resuming your CPR and still you are not able to revert the patient. Now you need to think about the reversible causes of cardiac arrest. The reversible causes of cardiac arrest are very simple, guys, which are 5 H's and 5 T's. 5 H's and 5 T's. 5 H, 5 T's. What is the 5 H's, guys? Hypoxemia, hydrogen ion acidosis, hyperkalemia or hypokalemia, right? Hypoxia, hypothermia. These are the causes that we need to remember. Okay? In the explanatory classes, I have explained how to remember them and all. Okay? So this 5 H's. Next is about 5 T's. 5 T's meaning what? 5 T's. 2 T's will be connected to the cardiac side. 2 T's will be connected to the pulmonary side. And 1 T is for the toxin. What is the 2 cardiac T's? Cardiac tamponade and coronary thrombosis. Whereas the 2 T's of the pulmonary circuit are what? The pulmonary thromboembolism you have to remember, as well as tension pneumothorax. Pulmonary thromboembolism you have to remember, thrombosis or tension pneumothorax. And the last T is toxins, whether the patient is under the effect of some drugs or not. So 5 H's and 5 T's, you need to find out the causes of it and you need to rule out those 5 H's and 5 T's if the patient is still not being reversed. Okay, after giving amiodarone. Okay, so that is basically you are still continuing, you still continue unless and until you revert the patient, or it is 40 to 45 minutes till the patient is not being reverted. That means what? The patient is now dead. Now guys, imagine in the second step, while imagine you kept the defibrillator, you are looking for the rhythm, and now you don't get that rhythm. You get what rhythm, guys? You get this kind of rhythm. This kind of rhythm. Or sometimes you might get a normal rhythm also. But there is no pulse. What does it mean? Or remember guys, sometimes you might get this rhythm. Or sometimes you might get a flat line. This is called as asystole. Okay? Sometimes you might see this kind of rhythm. Right? Sometimes you might see asystole. What does it mean? Patient is not having pulse but is still having rhythm. It is basically called as pulseless electrical activity. If you see pulseless electrical activity or asystole, what you need to do? Will you deliver the shock? No sir, shock is delivered only for shockable rhythm. Over here what we need to do guys? Again, we need to go for the algorithm where we have to immediately just start your compression. Immediately start your, if there is asystole or pulses electrical activity, immediately resume your compressions and start to give epinephrine as soon as possible. Every 3 to 5 minutes you have to give epinephrine, right? And after again 2 minutes you check for the pulse and rhythm. If it is a shockable rhythm, then after 3 shocks you need to go for amiodarone and you need to treat for the, and you need to look for the management of reversible causes. If it is a non-shockable rhythm, then after 2 rhythm checks, you have to go for management of the reversible causes. Why? Because in shockable rhythm, you are totally depending on the defibrillator so that it can revert the heart rhythm to a normal rhythm. Okay? Whereas in the case of non-shockable rhythm, after the second, in the second rhythm check only, after the first rhythm check, you continue CPCR and give epinephrine. In the second rhythm check, still if it is non-shockable, you try for treating the reversible causes that we have already discussed. The 5 H's and 5 T's we have already discussed. Okay. Now guys, the next thing that we need to discuss is about monitoring in anesthesia. So what are the things that you monitor in anesthesia? The things that you monitor in anesthesia are, you monitor the patient's oxygenation. How will you monitor the patient's oxygenation? By pulse oximetry. Pulse oximetry. Simple guys. Second thing you monitor is, you monitor the patient's ventilation. How will you monitor the patient's ventilation? The best way to monitor the patient's ventilation is by capnography. Chest movements can also be seen, but the best is capnography. Third is, you monitor the patient's circulation. The circulation of the patient can be monitored by what? It can be monitored by BP, which consists of IBP and NIBP. What is IBP? Invasive blood pressure monitoring, in which the best site for checking the BP is, the best site to cannulate is the radial artery. Okay? NIBP is non-invasive, the conventional method of checking the BP. Okay? Next thing in circulation is ECG. 2 leads are very important. Lead 2 monitors arrhythmias, whereas lead 5 helps in detecting intraoperative ischemia. The third monitoring is transesophageal echocardiography. This transesophageal echocardiography is not done for routine cases. It is commonly done for a person who undergoes a major surgery, or where you are suspecting venous air embolism, and air is being introduced into the systemic circulation is called as venous air embolism, where you see a windmill murmur. Okay, so in that, for venous air embolism, the best investigation that needs to be done is transesophageal echocardiography. The next thing in the monitoring that we do is what? You monitor the patient's temperature. Again, you monitor the peripheral and core. Peripheral temperature is commonly used in normal surgeries. Core temperature monitoring is done for, again, major surgeries. And the best site for measuring the core temperature, it is what, guys? It is the pulmonary artery. Pulmonary artery is the best site for core temperature monitoring. The next thing that you monitor is, you monitor about the awareness. Is the patient awake during anesthesia or not? Okay? Normally the patient won't be aware. If the inhalational agent that you are using in the maintenance phase is not working properly, or the amount of inhalational agent that you need to use is not delivered to the patient. Why? Because you did not calculate it properly. Sometimes it can happen, guys. MAC values are differing from individual to individual, right? So remember, awareness can happen. But how will you come to know that your patient is awake? By base monitoring. What is base monitoring, guys? Base monitoring is by spectral index monitoring. That calculates the sum of EEGs. EEGs is electroencephalogram. Okay, guys? So that was regarding the monitoring, and that was regarding the rapid review session over here, guys. Hope this is helpful for you to crack all your competitive exams. Okay guys, always be confident while trying to solve the MCQs and all. Okay guys, thank you.